moving fast through 5 core areas: body fluid compartments, parenteral fluids, sodium, potassium, and wrapping up with magnesium, phosphorus, and calcium. Let's hit the ground running.
Section 1, body fluid compartments. We've got to start with the foundational physiology, because if you don't know where the water lives, you literally can't replace it properly. So in a typical adult, total body water makes up about 60% of lean body weight, and that strictly divides into the classic 60-40-20 rule. 40% is intracellular fluid and 20% is extracellular. From there, that extracellular fluid splits again into interstitial fluid and plasma. Now, why do we memorize this? Because it dictates exactly where your IV fluids are going to go. If you give free water, it distributes absolutely everywhere. But if you give isotonic saline, it stays entirely locked in that 20% extracellular space.
0.5 to 1.0 milliliters per kilogram per hour. Seriously, burn this number into your brain. It's the absolute baseline threshold for adequate urine output in adults. Whether you're just hanging maintenance fluids or aggressively resuscitating a patient with massive intraoperative deficits, this is the exact metric you're constantly titrating your fluids to hit.
Moving right along to Section 2, parenteral fluids. We know the patient needs fluid, but what exactly are we pulling off the shelf to replace those pre-op, intra-op, and post-op deficits? You've basically got 2 weapons here, crystalloids and colloids. Crystalloids, like normal saline and lactated ringers, are cheap, they distribute uniformly, and they are the undisputed first-line choice for resuscitation, including septic shock. Colloids, like albumin and hetastarch, have large molecules that keep them in the blood vessels longer at first. Sounds great, right? Well, they're super expensive, and the landmark SAFE study proved they actually offer 0 significant survival benefit over normal saline for ICU fluid resuscitation. So stick to crystalloids first. Now, within those crystalloids, the composition dictates the clinical use. Lactated ringers is essentially extracellular fluid in a bag, which makes it a perfectly balanced salt solution ideal for massive GI losses. Normal saline, on the other hand, packs a heavy 154 millimoles of sodium and chloride. Because of that specific makeup, normal saline is your go-to weapon when you're battling hyperkalemia, hypercalcemia, hyponatremia, or metabolic alkalosis. And D5W, it's hypotonic. You use it strictly to replace free water deficits, never ever for volume expansion.
That takes us perfectly into Section 3, sodium disorders. Sodium balance is mostly handled by the kidneys, which manage a normal daily dietary load of about 130 to 217 millimoles. When serum sodium drops below 135, you have to follow a strict diagnostic pathway. Step 1 is always measuring serum osmolality to classify it as hypotonic, isotonic, or hypertonic. If it's hypotonic, meaning we have true hyponatremia, step 2 is a rigorous look at their volume status. Are they hypovolemic, euvolemic, or hypervolemic? Your entire treatment plan completely branches off based on those 2 initial assessments.
Now, for severe symptomatic hyponatremia, where sodium plummets below 110 millimoles per liter, that is an absolute emergency. You need 3% hypertonic saline, often paired with a loop diuretic like furosemide. But listen closely. Here is the life-saving rule you cannot forget. Your initial correction rate must never exceed 1 to 2 millimoles per liter per hour. If you correct it too fast, you rapidly suck water right out of the brain cells, triggering central pontine demyelination. That is irreversible, catastrophic neurologic damage. Don't do it. To safely hit your target without overshooting, you have to calculate the exact sodium deficit. You take 0.60 times their lean body weight in kilograms and multiply that by the difference between our target of 120 and their measured sodium. We use 120 because the second serum sodium hits 120 millimoles per liter and their symptoms resolve, you immediately pull the plug on the hypertonic saline. On the flip side, we have hypernatremia, where sodium is over 145. Just like before, you categorize patients by their extracellular fluid volume status. Hypovolemic patients are losing water either externally or through the kidneys. Euvolemic patients have pure water loss, like what you see in diabetes insipidus. And hypervolemic patients, that's usually iatrogenic sodium gain, meaning, well, we caused it. Regardless of the bucket they fall into, your primary mission is free water replacement. You calculate exactly how many liters of free water they're missing using the water deficit formula. But again, a massive warning here. Dropping sodium too quickly causes water to rapidly flood back into brain cells, leading to fatal cerebral edema. You must only replace 1/2 of the calculated water deficit in the first 24 hours. The rest is corrected slowly over the next 2 to 3 days.
Section 4, potassium disturbances. Remember, potassium is the king of the intracellular space. Only 2% lives extracellularly, which means even tiny shifts make a massive, life-threatening difference.
The most critical exam and clinical findings for potassium always come back to the heart. With hypokalemia, when it drops below 3, you're looking for T-wave depression and prominent U waves on the ECG. But hyperkalemia, that is an escalating time bomb. It kicks off with symmetric, peaked T waves, then widens out the QRS complex, and if you don't intervene, it flattens into a deadly sine wave pattern right before cardiac arrest.
When you see those hyperkalemic ECG changes, or if potassium is just flat out over 6.5, you execute this exact 3-step sequence. Step 1, push calcium gluconate immediately to stabilize the myocardium. It doesn't actually lower the potassium, but it stops the heart from stopping. Step 2, temporizing shifts. You shove potassium back into the cells using sodium bicarbonate, insulin with dextrose, or inhaled albuterol. Step 3, definitive excretion. You have to physically get the potassium out of the body using KX-Elate, loop diuretics, or if they're refractory, dialysis. Memorize this sequence. Just do it.
We are in the home stretch. Section 5 is a rapid-fire breakdown of magnesium, phosphorus, and calcium. Derangements here usually run together, especially in malnourished or critically ill surgical patients.
Let's start with magnesium. Our clinical target isn't just normal. We actively push it up to the upper limit of normal, right between 2 and 2.5 milliequivalents per liter. Why? Because hypomagnesemia causes dangerous QT prolongation and ventricular arrhythmias. Plus, low mag makes the heart super susceptible to digitalis toxicity, so you really want to keep those levels high normal.
Next up is phosphorus. Severe hypophosphatemia is incredibly dangerous, causing profound respiratory muscle weakness, and it is the absolute hallmark of refeeding syndrome. Repletion here is highly standardized. The IV dosage in millimoles scales based on the severity of the drop and the patient's weight here. And here's a crucial clinical pro tip. Check their potassium first. If the potassium is low, you use potassium phosphate. If it's high, swap it for sodium phosphate.
Finally, calcium. Total serum calcium exists in 3 forms. 40% is bound to protein, 15% is complexed, and 45% is ionized. The most crucial takeaway for exams and clinical practice is that only the free, ionized portion is physiologically active. Because protein and albumin levels fluctuate so wildly in stressed surgical patients, the total calcium number can completely lie to you. Always check the ionized calcium to assess for true hypocalcemia. And remember, it's intricately regulated by parathyroid hormone and vitamin D.
Okay, we've rapid-fired through the numbers, the formulas, and the strict protocols. But I want to leave you with this final thought. You can push the calcium, you can flawlessly calculate the water deficit, and you can make the monitor look perfect. But have you treated the underlying cause? Whether it's an unrecognized GI leak, acute kidney injury, or hyperaldosteronism, expertly masking the electrolyte numbers is really only half the battle. Find the source, fix the real problem. Thanks for joining this explainer. Now go crush it on the wards.